Hello, good evening, everyone, and welcome back to our IVF webinar. This time again with Andreia Trigo. Hello, Andreia. How are you feeling tonight?
Hi, Caroline. I'm feeling great. How are you?
I'm feeling great that you are able to join us once again, and you've been here last week, and I'm very, very excited to have you back. And thank you already for joining us once again and presenting this particular topic as well. This is definitely important for all the patients. This is like the very, very beginning of our whole, I would say, point of being here even.
Mhm.
So thank you so much for bringing this topic to us. And of course, hello everyone, and thank you so much for joining us tonight. I do hope that you had a good day and are ready to learn some things from Andrea. She has prepared a presentation for you as always, but also remember that after her presentation, you will have a chance to ask your questions. All you need to do is just type the questions in the chat section, and Andrea will be more than happy to help you. And if you don't know yet, Andreia Trigo, she is the multi-awarded nurse consultant, but also author and TEDx speaker, founder of Enhanced Fertility Programme, that is available as an app. You can find it on our, Google app, or also sorry, Apple, and I'm sure that it will be very, very useful for you. So go ahead and do it if you haven't already. I've seen it this myself, and it's been very, very interesting and amazing app for sure. And well, as you know, as you see today, we will be talking about fertility self-assessment tools and how can I check my fertility. This is a question that many, many, many of you, I'm sure, have been asking. So Andrea will be talking about this, and as I mentioned, she will talk also about. She will be able to take your questions. And as you know, we are here every single day. My IVF Fences. This is a part of European Fertility Society, and we are simply here to educate you, to support you, to provide you with as many answers as we can. And we definitely want to bring the top fertility experts, but also coaches. As you know, we've been doing some even we had yoga teachers, so it's been tremendous to be here and to present all of those topics to all of you. So yeah, I guess that will be it from me at this point. Andrea, are you ready to begin with your presentation?
I'm ready. Thank you
Happy
so
to hear this.
much,
Thank
Caroline.
you so much. Go ahead.
I'd like to initially to start by thanking you, Caroline, and everyone at the Society for inviting me to be here today. It's an amazing opportunity that you are giving to everyone to learn and to connect with the experts to help them in their journeys. And today I would like to talk about assessing your fertility and how can you check yourself and sort of make a picture of the global picture of how your fertility looks like. My idea for bringing this topic today has come from my experience of working with several patients as a nurse. And I often find patients that have had certain basic tests done and they are recommended for fertility treatment, which they have, and then treatment doesn't work. And then after a while, doctors might request further tests, and it can be so confusing for patients because they start asking themselves, why haven't I had these tests done before? Why am I doing them after I've been through invasive fertility treatment? And so my idea is to give you all the tools that you can possibly have to assess every single aspect of your fertility and get a global picture so you can make an informed decision about what treatment to try. And ultimately, if you know what is your risk factors, your problems, you are also having a more informed decision about the chances of conception, whether you try naturally, whether you try with treatment, whether you try with treatment with different protocols. So I would like to bring some clarity both to you and to doctors and clinicians in general. So this is what I will talk about today. But for those of you who don't know me, I am a nurse and I'm very passionate at doing what I do, helping people get pregnant. And my mission came from my own experience with infertility, because I was actually diagnosed with infertility when I was 17. And it was very challenging for me to cope with it at that time. So I've made it my mission to give back to this community, combining my personal experience as well as my skills as a nurse, as a researcher, as a lecturer in this topic. So I want to give back to this community. So it's with all my heart that I participate in all these webinars and all the initiatives that are available to give back as much as possible. Over the last few years, I've been trying to make fertility education, support, and care accessible to everyone. I don't think support should be an add-on. I don't think it should be difficult to find access to trustworthy information. But the reality is that it is really hard to find the information that is trustworthy, that you can truly rely on. So that's out of that idea that the Enhanced Fertility Programme app was born. So this app was launched in November last year. And like Caroline was saying, it's a free app that you can download from the Google Store or the App Store, and you have access to lots of things. Amongst them, an online fertility course with 5 modules. So you'll have short videos about each topic, and you have text, you have access to research, you have mindfulness recordings, CBT exercises, lots and lots of things that you can use to help you in this journey. And what I'm going to show you here today, you can also complete the fertility self-assessment in the Get Started button of the app. So I will talk to you about all the different factors that can affect your fertility today. But if you want to do the test yourself, to check your own fertility, you can go to the Get Started button and you can do that as well. So today we're going back to some really basic concepts to try and understand what your fertility risk factors are, because before we go deep into what might be wrong, we need to have a basic understanding of the normal process, what needs to be right to make a baby. And we need to reflect what can potentially affect my fertility, to then identify what tests do I need to be done to identify those things that could be wrong. So this is sort of the layout of what is going to happen during this hour that we're going to be here today together. I found this picture of a safe sex education class, and the teacher is saying, don't have sex because you're going to get pregnant and die. And I think this is the experience that probably all of us have had in sex education when we were younger. Maybe you can write in the chat, were you given the impression that getting pregnant was very, very easily, and that if you did have sex, you would get pregnant straight away? Was this the experience you've had? Yeah, I think that's everyone. And that's why most of us end up trying to avoid getting pregnant until one day we've realized that the problem is there and we weren't aware. But I think there's a narrative that needs to change, and we need to start talking more about fertility, conception, and what can we do to make the choices that we want to make for ourselves. In reality, getting pregnant doesn't happen very easily. And human beings are really, really bad at reproducing. I brought here these statistics of natural conception. We can see here a woman who is 25 years old has a 25% chance of getting pregnant in one cycle. So that, like I said, it's really, really bad. We're not great. I know other, animals in the world who are much better at reproducing, but humans are not at the top. If we look at women who are 35, their chances of conceiving naturally in one cycle are only 15% naturally. And that's because conception is actually a really, really complex process. Lots of things need to be right for conception to happen. The egg needs to be mature, needs to have the right number of chromosomes. The sperm needs to be developing normally, needs to have the right number of chromosomes, needs to be able to go through the vaginal canal, to cross the cervix, to go through the uterus, to go through the fallopian tubes to meet the egg. After fertilizing, the egg and the sperm, they need to multiply correctly. Then they need to travel to the uterus to implant. And the uterus needs to be ready to receive the fertilized egg. So as you can imagine, this is a huge journey for that sperm and that egg. And there's lots of things that can be wrong from the sperm side, the egg side, the embryo when they're already combined, or even from the uterus side and the environment where implantation takes place. So those are several things that could be contributing to potentially lowering these chances of conception even further. Now, if we look at here at the chances of conception with fertility treatment, this is a graph from HFEA here in the UK, and it might seem a bit complicated, but I will take you through it. If we look at here, this black line, this is the patient age. And it's telling us the average patient age. So most patients who have one cycle, they are 34 years and a half. But the average the average age of patients who have, for example, 4 cycles, they are already 36 and a half. So the age increases. We know that the birth rate remains around 20% per embryo transferred. So it is slightly higher compared to natural conception. And we know that it remains at around 20% or higher for the first 3 cycles. And this is the main reason why NICE recommendations recommend 3 cycles for everyone here in the UK to be funded by the NHS. We know that doesn't happen, but it comes from this likelihood that we have a 20% chance of the first 3 cycles. And we need to reflect on the fact, why does the chances of success per embryo transfer reduce when we have, for example, 7, 8, 9, 10 cycles? And the main reason why it reduces and success starts being less is because the female age starts increasing. So by the time we reach to cycle number 7, we are much older than we were when we started cycle number 1. So the female age is an important factor to consider. So getting pregnant, unlike that teacher was telling us, is actually not easy at all. And it's good that we start having that understanding, and it's good that we talk about it and that everyone around us knows that it's actually a more complex process than everyone in school is letting us believe. So I'd like to start by the beginning. And I would like to start by looking at the egg that grows in the ovaries. So here we have the ovaries that are connected to the fallopian tube. And we are already born with all the eggs that we're going to have. We are born with actually between 1 and 2 million eggs, which is a huge amount of eggs. But by the time that we reach puberty, we have around 300,000 eggs left in our ovaries. In every cycle that we have, several eggs, hundreds of them, are going to start maturing. And we can see here the tiny ones, and they're going to start maturing. But there's only one who is going to complete the final stages of maturation, and it's going to be released from the follicle. this egg is going to be available for 24 hours to be fertilized. So the sperm, as we were talking before, it needs to cross the vaginal canal through the cervix into the uterus and come through the fallopian tubes to meet the egg. And actually, only 1% of sperm that is ejaculated actually crosses the cervix. So it's just a very small amount. It's fascinating. So we know that this process involves two cycles, the uterine cycle and the ovarian cycle. The uterine cycle refers to all the changes that are happening in your uterus, meaning menstruation, which is the shedding of the uterus lining, and then the proliferative phase as the uterine lining regenerates itself. Then we have ovulation, and then finally the secretory phase when the uterus lining is getting ready for implantation. The ovarian cycle matches these stages of the uterine cycle. They need to happen at the same time in synchrony. At the same time as you're menstruating, your follicles are maturing those eggs inside the follicles, and that's called the follicular phase. Ovulation happens in both cycles. And after ovulation, the follicle that was surrounding the egg is going to degenerate, and it's going to start producing progesterone. And it's that progesterone produced here in the ovary, in the luteal phase, that is going to allow the uterine lining here in the secretory phase to thicken enough to allow implantation. So it's important that these cycles, they need to have a certain duration. They need to have a certain synchrony between them. And that is important. That's one of the factors that we're going to look at when we are assessing your fertility. And then we need to look at the male aspect as well. And men are usually even less assessed. Their fertility is less checked to start with. So I think it's important for us to look at men as well. So men have sperm, and unlike women, men only start producing sperm when they reach puberty. So we're born with all the eggs we have. Men don't. Men will start producing when they are in puberty. And they're going to continue producing sperm every day of their lives, from puberty potentially until they die, but until they are very, very old, like in their 80s or 90s. Sperm, just like the egg, matures from very small cells until it divides itself, until it forms that shape that we all recognize with the head and the tail. And this whole process of maturation, unlike women, it lasts one cycle, right? In men, it takes around 74 days. So about 3 months for men to go from one cell to fully mature sperm. And in the testicles, we will find, because every day they're producing sperm, we will find different sperms at different stages of maturation as well. So it's interesting that testes will produce around 200 to 300 million spermatozoa every day. So very, very different to what women go through. Only around 100 million of those will become viable. But it's good that it's a lot, because we know it's only 1% of the ejaculated sperm will actually be able to cross the vaginal the cervix. An important aspect of sperm is that it needs to be at a lower temperature than our bodies. So women have their ovaries inside their bodies. We have our internal temperature, which is much warmer. The testicles are outside the body. And that's for a reason. That's because sperm doesn't like hot temperatures. So that's one of the things that we're going to assess as well in men. It's going to be the temperature and environmental factors that can affect that temperature, because with higher temperatures, spermatogenesis, the production of sperm cells, is not going to happen. I'm just giving you a very quick overall view of the basics. This processes, both the male and the female, they are regulated by hormones, and it actually starts here in our brain. And it's something that a lot of people might not be aware of, that our reproduction is regulated by our brain. And it's through an axis called the HPG axis. It seems like a very complicated name, but it's the H stands for hypothalamus, which is here in a part of our brain. The P stands for pituitary, which is another gland inside our brain. And the G stands for gonads. Gonads are the ovaries in women and the testes in men. And we know that the hypothalamus will produce gonadotropin releasing hormone, which is this one here. This hormone is going to trigger the pituitary gland to produce two very important hormones, LH and FSH. FSH is going to stimulate our ovaries to produce the follicles, and LH is going to trigger ovulation. But these, again, are produced in our brain. And the ovaries are going to produce estrogen and progesterone. And there is a feedback loop in the sense that as our eggs are growing, the follicles are getting bigger. The bigger they are producing more estrogen. When there's a certain threshold of estrogen, a message is sent to the brain to say, we're ready to be ovulated. The brain sends that message to the pituitary gland. The pituitary releases LH. And when LH reaches the ovaries, ovulation happens. After ovulation, then the follicle that was surrounding the egg degenerates and starts producing progesterone. So there's this constant feedback loop mechanism that is really important. So all of those hormones, if they are unbalanced, they could be affecting your fertility. So that is one of the things that we also need to look at in your fertility assessment. So as you've been able to understand in this short 20 minutes that I've been talking, fertility is not as simple as our sex ed teachers have led us to believe. And what I find is that a lot of couples who seek fertility assessments, common assessments that they receive are usually a medical history, where the doctor might ask you, have you had any problems? Have you had any surgeries? Doctors might ask you about your menstrual and your sexual history, about your cycles. They might do some hormonal tests to check some of those hormones. The doctor might do a gynecological examination to see if there's any anatomical changes, and they might do a scan to check your uterus and your ovaries. And for men, they usually do a sperm analysis. So this is very, very basic. And I think it fails to assess many, many things that could be wrong. And that's why so many times, many people are recommended to have fertility treatment, and then they need to have tests after they've had treatment in order to look for further causes. Some people are also labeled unexplained infertility before they're given all the other tests of what could be wrong. So I want to tell you a bit about all the tests that you could potentially have and what you need to check to make sure that you're not given that label of unexplained infertility before you check all the causes, because I think that's quite important. We often want to know the reason why, what is causing my problem. Because many times if we find a cause, we can also address the cause and find a solution to the problem. So, like I said, everything that I'm going to tell you today, you will be able to do the test for yourself. And as opposed to those 5 or 6 tests that I've showed you now, the basic tests, what this test does is you have 50 questions about your female fertility and 35 questions about male fertility. So as you can see, it's very, very thorough. It takes you about 7 to 10 minutes to complete, so allow enough time to complete it. And it categorizes, depending on the answers that you give, it categorizes them into low, medium, or high risk of developing fertility problems. The idea is that we want you to have a global view of everything that is possibly affecting you. Because if you have a global view, and if your doctor has a global view of all the problems, he will be in a better position to suggest what treatment is more likely to work for you. I should tell you that this questionnaire, this fertility risk detection tool, is part of a research project, is research validated, and we are continuing doing research on it. So if you complete it today, you can complete it at any time. So if you feel that some of the risks have changed over time and you want to complete it again 6 months down the line, because you might have adjusted some of the things after doing the first questionnaire, that's perfectly fine. And we're actually working on a way for you to receive your answers in a way that is more visually appealing. So we have lots and lots of things happening at the moment, but do stay connected. So in the female factor, we have different domains. We're going to look at your cycle and your ovarian reserve. We're going to look at the gynecological history and health. We're going to look at genetic predispositions, supplements that you're taking, your lifestyle, and your environment. And for men, we're going to look at sperm, but we're going to look at more than sperm. We're going to look at male health. We're going to look at genetic predispositions, lifestyle, and environment as well. And I'd like to give you certain examples of things that you can test. So we have here one of the most important factors that we've seen is age. Unlike many people believe, men do have a biological clock just like women do, but it's not as early as ours. So we can see here that women, our peak fertility happens when we are in our 20s and will stay up to it will stay good until we're 35. But it will start deteriorating at that point. So if your age is between 35 and 39, you are in a moderate risk. If you're above 40, you will be at a higher risk already. For men, as we can see, it starts a bit later, but they still have a biological clock. And it's important to know that, because as men age, the likelihood of chromosomical abnormalities in the sperm also increases. Then we have here the menstrual cycle, and we're going to look at how regular your cycle is. And this is a simple question of yes or no. Your cycle is regular if it lasts on average the same number of days from cycle to cycle. It can change up to a couple of days from cycle to cycle, but no more than that. So if you are, for example, a cycle of 22 days, and then the cycle changes to 30 days, and then to 20 days, so that would be irregular. The change from cycle to cycle can't be more than just a couple of days. Then we're going to look at the length of the cycle. Here, we're going to look at the first day when your period starts, and we're going to continue counting until the last day before your next period, and that is the length. And we know that even though usually research talks about 28-day cycles, but only a small percentage of women actually have 28-day cycles. Usually, most people will have anything between 26 and 35-day cycles, and that's absolutely normal. We need to be concerned if cycles are above 35 or less than 26 days. And then we're going to look at ovulation. Ovulation is really important, and we want to know whether ovulation is happening if you have been tracking your ovulation, and there's different ways to track ovulation. If you're tracking, for example, your LH hormone, we know that without LH, remember that cascade that was coming from the brain, without LH, there is no ovulation. So that's a pretty good marker. And that's what you would test with those urine sticks. If you're using a temperature test, the temperature is going to give us an indication that there has been a progesterone release. So it will give us an indication that ovulation has already happened in the past, but there is no chances of conception anymore in that cycle because the fertile window has passed. So we want to know whether you are aware of your ovulation time, if you've been tracking, and if you've been having sex in the right time. Because we, like the teacher in the first photo, you don't touch someone and that person gets pregnant, right? We need to have sex at the right time. So we need to make sure we're having sex during ovulation time. Then we're going to look at ovarian reserve. And this is one of the biggest findings. We've done already 200 people who have answered this survey. And the vast majority of people didn't know their AMH levels, but they had been trying to conceive for more than a year. And that for me is concerning because AMH is an important test to have. And it's a marker of ovarian reserve, how many eggs you have left in your ovaries. And as you can see here, it changes with age. And I've also put different units because depending on the laboratory where you have your test done, if it's here in the UK, in Europe, in the US, it might come as nanograms or pmols per liter. So just make sure you check the units if you've had your AMH tested and you check if your value is normal per age. So we want to know your AMH levels, but we want to combine it with the antral follicle count scan. And this scan is important because it's going to allow the doctor to count how many follicles are in your ovaries. And it's only when we have these two together, these two tests together, that we can actually say what is your ovarian reserve. We cannot give you 100% certainty that your ovarian reserve is actually low or high if we just do an AMH test. So we want to have both. And so many people either haven't had any test done or they've had AMH but not the scan. So just bear in mind that to have an accurate view of what is happening in your ovaries, it's important to have both tests. And then we are going to look at several aspects of your gynecological health. And here I have some of them. We're going to look at hormonal problems. So we're going to look at all those hormones that have an impact in the HPG axis. We're going to look at pelvic inflammatory disease, whether you have it or not. We're going to look at the presence of fibroids. And we're going to look at where are these fibroids located. So this would usually be diagnosed with a scan or with an exam that would look inside your uterus. And we need to see if these fibroids are, for example, obstructing your fallopian tubes, preventing the sperm from meeting the egg, or they might be affecting implantation if they are very large, preventing the fertilized egg from implanting inside the uterus. We want to know if you have any uterine malformations. Here, it can be to an extreme. For example, I was born without a uterus, but it can be to less extent where you have women who have a septum, like a wall dividing the uterus in half. And that is a problem if you have a septum because the septum is not as vascularized as the rest of the uterine wall. So if the embryo implants there in the middle, it's less likely to survive. So you might need to have surgery to remove that uterine septum. We want to know if you have endometriosis or not. We know it happens to 1 in 10 women, and so many times women go undiagnosed for extended periods of time without endometriosis. We want to know if you had previous surgery, if you had, for example, if you've had surgery to your bowels, or if you've had surgery in your pelvic area. Every time you have surgery, there is scar tissue that can be affecting your reproductive system. We want to know if you've had a test to check whether you have blocked tubes, for example, and we want to check if you have been diagnosed with an autoimmune disease. So as you can see, we're checking all possible things, both anatomical and hormonal, that could potentially affect your fertility. And then we're going to look at lifestyle, which I know many times lots of clinics don't look at, but the BMI is an important one. So we're going to look at your BMI and how that might be affecting fertility. We're going to look at food intake, whether you're eating healthy most of the time or less often. We're going to look at your activity levels, whether you smoke or not. We're going to look at alcohol intake, coffee intake. We're going to look at your sleep patterns. Sleep is really important because it can dysregulate our hormones as well. So, and I know it can be really difficult because when we're feeling super stressed with fertility and with work and with life, sometimes we don't sleep as well as we would like. And we're going to look at your stress as well. And there's other stuff that I haven't included here, but we're going to look at your quality of life, your ability to cope with treatment. And why are these important? These are important because fertility is more than just physical. Fertility is a well-being that comes from physical, emotional, psychological, and social impact. And this is the definition of the World Health Organization. So we want to look at all aspects. We know that if we are more stressed, we're more likely to have a diet that is rich in high caloric foods, which we know is bad for fertility. So all of these things tend to be interconnected in some way. So it's important to have the global picture. And then we're also going to look at your environment. We're going to look at toxins like BPA and phthalates. These are present in everyday items. For example, in plastic containers that we use to storage food. If we start thinking about everything that we buy in the supermarket comes in plastic. And BPA is a chemical that is used in plastic, so it can leach into the products that we end up either eating or putting in our bodies. Phthalates give a nice fragrance, a nice smell to things. So if our shampoos, body wash, creams, they all might have this fragrance unless they are scented with essential oil. So it's just being mindful of the toxins that we are putting in our bodies because they can cause changes to the DNA in our eggs and sperm. Sperm tends to be a bit more fragile in that sense, but it's important that we are aware of that. And then also these toxins that can come either through the air or through the water. For example, pesticides that are added to food that is being planted, and then it goes in from the water to the food that we end up eating. So it's important for us to have that global view. So after you've answered 50 questions about your female fertility, it's time to answer some questions about sperm. And this is the initial basic sperm analysis test that most men will have done. We're going to look at the concentration, the number of sperm in that sample. We're going to count how many are there. We're going to check motility. Motility is whether they are moving. We're going to check progressive motility, which is, are they moving forward? Because sometimes they're moving all in the same place, and that's not going to help if we want them to go up the vagina through the cervix. We're going to check vitality, how many of them are alive. We're going to check morphology. Do they have the normal shape? The head, midsection, and the tail. Sometimes they have two tails, two heads, so we need to check. And then I've added here DNA fragmentation, because many times this is not part of the sperm analysis. So you just need to check if you've had a DNA fragmentation test or not. This is useful because sperm might look good, but when you check their DNA, it's actually abnormal. So it's important to do the DNA fragmentation. And I know that some clinics will do a sperm analysis and include DNA fragmentation, and others don't. So just know that your sperm analysis might be good, but when you look at DNA, it might be bad. So it's good to be aware of that. In terms of male health, again, male are so under-assessed. They're not looked properly, but they do need to be assessed because they are actually 50% of the equation. We want to know whether men have had any previous surgery. And here we're talking at, for example, surgery that they might have had in their testicles. For example, a torsion that might have happened. We want to know if men have had surgery, for example, for an inguinal hernia, which is a hernia here on the side. And it's quite common for them to do, when they have surgery, it's a possibility or risk that they cause damage to the canals that transport the sperm. One of the most undetected male problems is varicocele. This looks like varicose veins in the testicles, and it's a problem because it increases the temperature of the testicles, and then sperm doesn't produce normally. So this requires a visual examination of the testicles. So the doctor would need to examine that. But again, so many men are not assessed, but you can probably look at your own testicles and check if you have varicocele. It can be quite striking. We would like to know if men have had mumps. Mumps is a viral infection that was quite common before the MMR vaccine was introduced. And it looks like an inflammation here in the parathyroid glands. And it just looks like an inflammation, but men might not remember if they have had that infection or not, but they can ask their parents. And this is quite important because it can affect fertility. We want to know if men have been diagnosed with an autoimmune disease, if they have hormonal problems, previous sexual transmitted infections. So, for example, any infection that, for example, chlamydia, can end up having an effect in fertility. And we want to check men's vitamin D levels. Vitamin D comes from our exposure to the sun, but depending where you live, you might not be exposed to too much sun, like we here in the UK, where we don't have too much sun. So it's very likely that our vitamin D levels are low. In men, this is important because if your value of vitamin D is below 20 or above 50, it can affect sperm. So we would like, first of all, for men to have their vitamin D levels assessed. And then we would like men to have their hormones checked as well. Testosterone, which is produced by the testes, is quite important for spermatogenesis. So we want to know if their values are normal or not. Here in lifestyle, we're going to look at the same aspects that we looked at male. So we're going to look at BMI, food intake, activities, smoking, alcohol, coffee, sleep, and stress, all of those that we also questioned in female. But we're going to also ask about testicular heat. And testicular heat is about checking whether the testicles are exposed to too much temperature. We explained that the testicles like to be at the lower temperature than the body. So there are certain things that could make them increase temperature. For example, very tight underwear or very tight trousers, sitting for longer periods of time, or, for example, wearing the computer in their laps, or going to hot sauna. All of those things that increase the temperature of the testicles are not good. So we want to do an assessment of that as well. And then, just like in the female, we're going to look at the toxins, again, BPA and phthalates. Sperm is much more fragile to those toxins than the egg. It's more likely to be affected by oxidative stress. When oxidative stress is like, imagine a car that is working, and when the car is working, it's expelling the fumes, so all the toxins that we don't want. In our body, our normal cells will start producing that rubbish, those toxins. However, when we are putting more toxins into our body, our cells need to work extra hard, and sometimes they cannot expel at the same rate as they're being produced. So that causes oxidative stress and causes DNA damage, and sperm are quite fragile to that. So here, I want to just to give you some key takeaway points. I don't want to scare you. I just want you to know that there's lots of things that you can look into that could potentially give you an insight into what could be wrong. I am of the opinion that knowledge is power. So the more we know about our bodies, the more we will be able to make informed decisions about treatment. And the same happens with your doctors and your nurses and your clinical teams. The more information you give them, the better they will be able to help you. So if you give them lots and lots of information, they will more be able to give you in a meaningful way. To summarize, fertility and conception are not as easy as we were taught. We can't just get pregnant if we are sitting next to a boy. That's not how it happens. There are several things that need to be right to make a baby. The egg needs to be right, the sperm needs to be right. There needs to be a way for the sperm to meet the egg. They need to fertilize and multiply, and then they need to travel and implant. So lots of things in this process need to be right to make a baby. The basic fertility tests that are done to most people, they don't test for the majority of the things that can go wrong. And that's why I would like to invite you to complete the questionnaire. If you are still not sure about what might be wrong, complete so you know what can be done, what else can you do about your situation. It will give you an insight into further tests that you might need. For example, it might ask you things that you never had done, but that's okay because now you know it's important to have that done. And it gives you an opportunity as well to discuss those results with your doctor and your nurse so that you can create a fertility plan. And I think that is the ultimate taking back the power of this awful, awful situation that we all found ourselves in, but it's taking back the power, and that's what I love so much about it. And I think I'm ready to take any questions, and I'm sure I'll share the link with everyone at the end to complete the questionnaire. But I'm ready to take any questions. Hi, Caroline.
Yes, I'm right here, of course. Thank you so much indeed, Andrea. It's been wonderful to listen to you and all of the tips you have provided. Thank you so much. It's always so easy when you explain this, really. So thank you so much. And well, I definitely agree. Knowledge is power, and that's why we are here to support you. And thank you already for so many questions, Andrea. You can see them right here as well, I believe. Yeah, and well, let's get to them straight away, okay?
Okay.
Perfect. Okay, Karen is first. Sorry to hear that you had your own challenges with infertility, Andrea. However, kind that you've used this for good to help so many of this. Thank you so much. So this isn't a question, but I definitely
Mm.
wanted you. Thank you so much.
Yes.
And yeah, Karen has another question right here as well. During IVF cycle, the levels in my blood show as good, and I have 6, 7 good sized synchronized follicles. However, the
Mhm.
action is very low. Is it possible that day 21 progesterone test could indicate ovulation is likely, but that no egg is released from the follicle?
Okay, so let me see if I understand. So you have 6 to 7 good follicles. However, when you have the egg collection, there's a small number that is actually retrieved. And you're asking if it's possible that the day one progesterone could indicate that ovulation is likely. Yeah. So sometimes that does happen, that the follicles develop, but the eggs inside those follicles didn't actually mature. And that is a risk that we take with ovarian stimulation. Um, it Doctors usually refer to patients who might have, for example, a good AMH and a good antral follicle count, but then who respond to ovarian stimulation in a way that is less than what would be expected for their age and for those AMH and follicle count levels. And doctors usually call those a poor responder to ovarian stimulation. And it might be that the doctors could try a different ovarian stimulation drug to see if it makes a difference. But I think it's a matter to try different things before giving up, because you might respond differently to different medications. And I think in the last part you ask if progesterone could indicate ovulation is likely, but no egg is released from the follicle. Okay, so progesterone is produced by the degenerated follicles. So if your progesterone levels are high, that means that ovulation has happened. However, if the progesterone levels are low, it could be that there was no ovulation. In a rare scenario, there's also something called LUF, which is luteinized and ruptured follicle, which is when there is stimulation, there is LH, the follicle is stimulated, but still ovulation doesn't happen. And that happens in very rare cases, but mostly in situations of unspecified cause of infertility.
There is a follow up, okay, from Karen. So have a
Yeah,
look at it, please.
my response appears very good, but they have trouble getting the eggs out. I'm not sure how would that be. I'm not sure why would they have problem getting the eggs out. So they would typically use a syringe to collect them. Is it a problem with accessing the ovaries? Sometimes the ovaries are a bit hidden, and it might be difficult collecting them through the normal approach, which is through the vaginal wall. But if they are able to get to the ovaries, they wouldn't have problems getting the eggs out. So I'm not sure if my answer could be of any help. But the only thing the medication does is stimulate the ovaries to produce more eggs in that cycle. Is it possible that good size? Yes, it is possible that the follicles grow, but that they don't have mature eggs. That is possible. And that's because we have millions of follicles with eggs at those very tiny stages, but then we are forcing them to grow, and some of them, the eggs do not mature in time. It is possible.
All right. Thank you so much for the very first question, Karen. And of course, Andrea, as always, for your advice. I do believe it has been very, very helpful as well. Okay. Thank you. And let's have a look. Okay. There are more questions coming up. So let's have a look at the next one. So, is there a correlation between AMH and expected number of follicles?
Yes. So we would expect, if you have a very low AMH, you are less likely to have a higher number of eggs if you are going through ovarian stimulation. That is the likelihood. So because AMH is produced by the follicles, the bigger the follicles, and the more follicles you have, the bigger your AMH is. But I would like to highlight here, just Caroline and Leticia, that, for example, women who have PCOS usually tend to have bigger follicles, but not necessarily very good quality eggs inside those follicles. So you might have usually higher AMH levels because of big follicles if you have PCOS, but not necessarily great quality eggs inside. But the number of AMH is related to the size of the follicles and the number of them.
All right. Again, thank you so much indeed again for that question. And Andrea, again, thank you. Let's have a look. Okay, Karen has added one more question. So, can diagnostic laparoscopy cause scar tissue?
If it's just diagnostic, it's very unlikely that will cause scar tissue, because what they do in the diagnostic laparoscopy is just put a camera in your tummy just to have a look, have a look around, and then they don't do anything apart from that. If they do surgery through laparoscopy, because what laparoscopy means is just surgery that is done through keyholes in our abdomen. So if they end up doing any treatment through the laparoscopy, then they could cause scar tissue. For example, sometimes there can be surgery done in our bowels that is done through laparoscopy, and that could cause scar tissue. But if it's just diagnostic to have a look, it would not cause scar tissue.
All right. And when we are around this topic, there is another question actually. So, how can you know if you have scar tissue after a surgery procedure?
Well, you would know only if the doctor would look inside again. So it's not a very feasible way to know. But the more invasive the surgery and the procedure, the more likelihood to create scar tissue. Now, I've spoken to several physiotherapists recently who do a lot of work in the abdomen to help release that scar tissue. So if you've had surgery in your bowels, for example, extensive surgery, it might be a good idea to speak with a physio who could help assess your abdomen and see if they could do abdominal massage to release some of that scar tissue.
All right. Again, thank you so much indeed. And let's have a look at the next question, this time from Vanessa. So, I have high levels of prolactin. Is there any supplements I can take to lower my levels?
So I think it would be important for the doctors to identify why is your prolactin levels high. I don't think, I'm not sure if there are any supplements that can address that, but it's important to know that supplements are medicines that haven't been researched. So they haven't been through clinical trials like proper tablets and medications have. So I wouldn't, high levels of prolactin are something serious. So I think you need to speak with your doctor to try and identify why is it high and what can you do, because you need to address the cause, what is causing it to be high to begin with.
All right. Again, thank you so much, Vanessa, for your question. And Karen has added one more question here. Can the Zymote machine prevent the use of fragmented sperm?
I mean, the Zymote machine helps identify potentially the best sperm for IVF, but I'm not I'm not sure if it tests for the DNA fragmentation. So I'd have to look into that into more detail. So I don't know if they have, if in their clinical trials they have correlated the selection process with DNA changes or not, but I can get back to you.
All right, understood. Of course, I can always forward this to Andrea, and I'm sure she'll get back to you as well. Okay, with further details. Thank you so much. Okay, let's have a look at the next question. So, what is the recommended level of vitamin D for women? Anything you
Yeah,
can add?
that is a great question, and there is no big consensus in different countries. So I think it will depend on what your doctor recommends. In men, it tends to be more important to be between 20 and 50. Uh, but I would say there isn't an absolute recommended level. But if you have a test done, it will tell you a range. So I would go with that. But just bear in mind that there's different countries giving different recommendations of what the ideal value should be.
All right. Again, thank you so much, of course, indeed, for that one. And there are like 3 questions left.
Mm.
We will be slowly finishing, but of course, I just want to remind everyone, if you have anything that you would like to add, go ahead and type this in right now. And let's have a look at the next question. So, does regular cycle mean ovulation by default?
Not necessarily. Not necessarily. So I think it would be important to identify whether you are having an LH surge. If you have an LH surge, so if you measure with those urine sticks and you can see a peak, that means that the follicle was stimulated and that ovulation is going to happen. You need an LH that is 2.5 above your baseline levels for ovulation to happen. And then secondly, I would measure either your temperature after a few days after ovulation. If the temperature is high, it means you have progesterone. It means that the follicle has degenerated after ovulation. So that could be a good confirmation that ovulation has already happened. Either that, or I know in some places, in some countries, you're also able to test progesterone at home. So the progesterone level could also be a confirmation of ovulation that has happened in the past. But it's always good to check if your hormone levels are being enough for ovulation to happen. Your LH needs to be high enough, 2.5 above your baseline.
And there was actually a follow up on that, actually, from another patient. Okay, so is
Mm.
LA stick different from ovulation sticks?
Yeah, that is a great question, and we could potentially do a webinar on this topic, Caroline. It's important because ovulation sticks will give you a smiley face or a sad face to tell you if you are ovulating, depending if your LH has reached a threshold of 40. The problem with that is that a lot of women have lower LH surges. So you might have an LH surge that ends up not being detected by your ovulation stick. And some women, particularly with PCOS, end up having a higher LH levels as well. So they might have false positives saying that, ovulation has happened when it hasn't happened. So if you are looking for a method to identify your LH, I would say that a method that tells you your exact value of LH, it's called a quantitative ovulation test, is better than just an ovulation stick that gives you a positive sign or a negative sign whether you're ovulating or not. So there's a few in the market, but if you look, for example, at MyLotos, they do one where you see your number exactly, and you might see your baseline LH is around 7, 8, 10, and then there's a day when it spikes to 50, for example. You know that you have ovulated because it's a 2.5 above your baseline.
All right. Thanks a lot, Andrea, for yet another idea for a webinar topic. Last time you've done that, we did have a webinar actually on diet, etc. So thanks a lot. It's definitely something that we need to remember because, as you mentioned, this is something that we could have a whole webinar on. So
Yeah.
yeah, it would take a while as well for us to cover that. So thanks a lot. Okay, let's have a look. Okay, more questions are coming up. Thank you very much for your lecture. It was very informative. I had 24 follicles and 13 mature eggs, and the eggs were fertilized. After the third day, the embryos stopped dividing. What could have been the problem?
Yeah. So I think if you go from 24 follicles, 13 eggs, I think that is a great number. So those 13 eggs, how many of them fertilized? Did they all fertilize, the 13 eggs that were collected? And then they stopped dividing on day 3. So I think we need to look at the sperm. Was there any problem in the sperm preventing it from, 13 fertilized? Brilliant. I think that is absolutely amazing. So I think you need to look at the sperm quality. You need to do the sperm analysis and the DNA fragmentation test. Because if you've had 13, that is amazing. We know that when we look at sperm quality, we usually talk about the DNA fragmentation to see whether there was any DNA changes. When we talk about the quality of the egg, there's no way of testing the DNA of the egg itself. So we only know if the egg is of good quality if it fertilizes and it continues developing. So I would say the next step would be to check the sperm, because if we know that the sperm is good and that there is no DNA problems, then we could go back to checking for egg problems. But I'm betting on the sperm. I think that would probably be the best next step.
All right. Again, thank you so much indeed for yet another explanation. And I believe that now it will be our final question. But of course, if you have any left, you know what to do. Just go ahead and type it in. And of course, Andrea, as always, you can see the thank you so much from our patient here. And the question for you is also here. Is there any treatment for follicular cysts? I get one in the first cycle after medication miscarriage because of stopped embryos heartbeat.
I'm not sure I understand the question completely. So follicular cysts, I'm not sure if you're talking about the cysts that are present in polycystic ovaries.
If you could let us know, of course.
Is it
Yeah, okay.
PCOS that you're talking about? PCOS usually has large cysts in the ovaries. Could that be? No, there is no PCOS. So I'm not, yeah. And you say that you get one in the first cycle after medication miscarriage. I'm not sure I understand this question, Caroline.
Of course, let's give it a second, okay? If you can just clarify that for us,
Yeah.
okay? Just to make sure. I believe our patient is typing it in
Yeah.
right now. So let's give it a minute. We definitely want to. Yes, just one after miscarriage. Uh,
One, one,
for,
one cyst. You had one cyst after a miscarriage.
let's wait and see again. I believe. Yeah, one cyst. Okay.
Hmm.
After miscarriage.
Yeah, I'm not sure. So cysts could be a problem because they could potentially affect ovulation. But if you've had a miscarriage, I'm thinking that you did have ovulation and the egg was fertilized, which is good. So, and then you say here, stop the embryo's heartbeat. I, Caroline, I think what I could suggest to just not to have the private conversation here is if we can send an email
Okay.
and I can have a one-to-one call that we can schedule for next week so we can understand the full story
Yeah.
and I can give some insight into what might have happened.
I totally understand. Of course, you would need more details just to be able to simply help out.
Mm,
So yeah, we can. Of course, we can do that. I'll be more than happy to forward this
mm,
to you. And well, if you wish to, we can definitely do that. I'm sure Andrea would be able to help you out and give you some tips as well. No, no, I'm sure of it. I mean, so thank you so much. Okay, we will be finishing. However, remember that if you would like to get in touch with Andrea, you know it is definitely possible to do that, and I am definitely sure she will be more than happy to assist you. Thank you very much as well again for all of your questions. Thank you, Andrea, for sending that. Of course, so if anyone haven't seen this yet, well, go ahead and do it. This is definitely helpful, so you can check it out. And well, Andrea, as always, it's always a great pleasure to have you here. And I can only say that Andrea will be back. Okay, don't worry, she'll be back. And again, thank you so much, Andrea. As you can see, lots and lots of thank yous. You
right.
just need to see them, of course, but
Yeah.
you see
It,
them, right?
yeah, it was a pleasure. I've added a link. So if you want to complete the questionnaire, it's in the Get Started button. And, you know, after you complete, you receive an email from me. So I'm more than happy to talk to you about your individual results as well and help you find a way forward. Thank you so, so much for joining today. A true pleasure to help all of you.
Thank you. Thank you indeed. Of course, we are definitely happy that you've been able to join us and you found this, I'm sure, very helpful. And as always, I just want to mention that we will be back with Andrea, but also we will be back tomorrow at 8 p.m. UK time. So I hope you can join us as well. We have another fertility assessment topic actually on PCOS. So just go ahead and register if you haven't already. And this webinar will be you will be able to find it on myivfanswers.com, but also on our YouTube channel tomorrow. And if you follow us on our Facebook, Instagram, you will see that there are plenty more events coming up also with Andrea. So I definitely hope to see you all back here as well, Andrea. Till our next event, as always, thank you so much and have a lovely relaxing evening. Thank you.
Bye, bye everyone.
Take care. Bye.